Welcome to the deep dive. Okay, so you've sent in these sources on varicose veins, and we're going to dig in today.
That's right.
Really cut through the jargon, and focus on what's happening now with treatments. Think of it as uh, getting you up to speed on the latest options.
Exactly. We've got chapters here from Rutherford's Vascular Surgery, the 10th
Yeah.
edition. It's pretty much the Bible for vascular specialists.
Right.
Our mission really is to pull out the key stuff, the most important bits about how varicose veins are actually being treated today.
And one thing that really jumps out right away is this big shift, isn't it? Away from the old style open surgery towards these, well, much less invasive techniques, endovenous treatments.
Yeah, endovenous, that's the key term. And the sources really emphasize the improvements, better safety, better results.
We're definitely going to unpack that.
And it's fascinating, this endovenous approach is now, like, the standard of care. The textbook lays out three main types we'll be looking at. There's thermal ablation that uses heat, so radiofrequency and laser. Then non-thermal, non-tumescent methods.
Bit of a mouthful.
Yeah.
Cool.
NTNT for short. That covers chemical stuff, mechanical, even adhesives like glue. And then there's sclerotherapy.
Got it. So different ways to tackle the problem. But maybe before we get into the treatments, let's just quickly cover the basics, the anatomy involved.
Good idea. So the sources talk about the superficial veins. These are the ones closer to the skin in your legs. They're the main collecting system, basically.
Collecting the blood.
Right, collecting blood and then channeling it into the deep vein system, which carries it back up towards the heart.
And the main superficial veins are?
The big players are the great saphenous vein, the GSV, that runs up the inside of the leg and thigh, and the small saphenous vein, or SSV, which is on the back of the calf.
Okay, GSV and SSV. I think I saw something about a duplicate GSV. Is that common?
Not really. A true duplicate main vein is actually pretty rare. What you see more often is something called an accessory anterior saphenous vein, the AASV. Think of it less like a whole second highway and more like a, significant side branch.
Ah, okay. So not really a backup. And then there are even smaller ones mentioned, reticular veins and telangiectasias.
Yeah, those are the smaller guys. Reticular veins are those sort of bluish ones, maybe 1 to 3 millimeters across. Telangiectasias are what most people call spider veins.
Tiny ones.
Really tiny, yeah. Like 0.1 to 1 millimeter. They're right near the skin surface. And interestingly, sometimes those slightly larger reticular veins act as feeder veins for the spider veins.
Huh. Like they're supplying them. Okay, that paints a clearer picture. So if someone's considering treatment, how do doctors actually diagnose the problem? There's this CEAP thing mentioned.
Right, CEAP. Stands for clinical, etiologic, anatomic, pathophysiologic. It's basically a standardized system, like a common language, for doctors to classify just how bad the chronic venous insufficiency is.
Based on symptoms and signs.
Exactly. Things like swelling, skin changes, the varicose veins themselves has been updated recently, and it's really crucial for figuring out the extent of the problem before deciding on treatment, especially these endovenous ones.
Makes sense. Standardizing things. And what about PRO scores?
PROs, patient-reported outcomes. Systems like the VCSS or AVVQ, these are questionnaires basically to gauge how much the vein problems are actually affecting your quality of life.
Ah, so pain, heaviness, that kind of thing.
Yeah, exactly. How much it bothers you day to day.
Yeah.
But for actually seeing the veins and the blood flow,
That's where the ultrasound comes in.
duplex ultrasonography, or DUS.
Yeah.
Yes, that's the absolute standard. It lets doctors visualize the veins, see the blood flow in real time.
Looking for reflux, backflow.
Precisely. Checking for that backward flow, reflux, or any blockages. And it looks at all the system's deep, superficial, and the perforator veins that connect them. Plus, it's essential for mapping everything out before treatment.
Okay, clear picture, good map. So now, treatment.
Yeah.
The goals can vary a bit, right? From symptom relief to cosmetic improvement.
Absolutely. It could be relieving pain or heaviness, healing skin ulcers if they've developed, preventing things from getting worse, or, improving the appearance of the legs.
And there's a principle about where to start treating.
Yeah, a key idea is to tackle the source of the reflux first. Usually that's the main connection point between the superficial and deep systems, either up in the groin, the saphenofemoral junction, or behind the knee, the saphenopopliteal junction.
Fix the main leak first.
Kind of like, address the highest point of leakage before dealing with the smaller downstream issues.
Now, the sources also mentioned this debate. Do you treat the main saphenous vein and all the visible smaller veins at the same time, or do it in stages?
Right, that's a point of discussion. There isn't one single answer, really. Some studies suggest doing it all at once might mean fewer visits for the patient.
More convenient.
Potentially. But other research indicates that just treating the main saphenous reflux might be enough, and some of the smaller varicosities could improve on their own once that main pressure source is gone. It really depends on the individual case.
Okay. So, given all these options, what are the big organizations recommending? The Society for Vascular Surgery, the American Venous Forum? What's their guidance?
Well, their guidelines are pretty clear now. They recommend endovenous thermal ablation, so RFA and EVLA, as the first-line treatment for symptomatic saphenous vein reflux.
Preferred over surgery.
Preferred over open surgery, definitely. And even preferred over foam sclerotherapy for treating the main saphenous veins, generally because of better long-term effectiveness.
But sclerotherapy still has its place.
Oh, absolutely. Liquid or foam sclerotherapy is the recommended treatment for the smaller stuff, the telangiectasias, the reticular veins, and even some smaller varicose veins. There's actually a helpful table in the textbook that kind of matches the endovenous option to the vessel type.
Okay, great. Let's dive into those thermal techniques then. Starting with RFA radiofrequency ablation. Minimally invasive, often outpatient, uses this segmental ablation. What does that mean exactly?
Okay, so think of the ClosureFast catheter. It has a heating element, right? Instead of treating the whole vein at once, it treats it in segments, 7-centimeter segments, one after the other.
Step by step along the vein.
Exactly. It delivers radiofrequency energy to heat that segment for about 20 seconds. This heat damages the vein lining, causes it to shrink down, contract, and eventually clot off and fibrose. Becomes scar tissue, basically.
So it seals it off section by section.
Precisely. And the Venclose device is another one that works similarly, using RF energy.
Are there times when RFA isn't the right choice? Any contraindications?
Yeah, the text lists a few. Like if you already have a clot, either superficial vein thrombosis or DVT, or a venous aneurysm, a bulge in the vein. Also, poor arterial circulation, like a low ABI score.
Okay.
A pacemaker isn't an absolute no, but you definitely need your cardiologist to sign off on it first.
Right, makes sense. So walk us through the actual procedure. What happens?
Well, first, hydration is important. Then, using ultrasound guidance, the doctor accesses the vein, usually the GSV, puts in a wire, and then slides the RFA catheter over the wire up to the starting point, just below the main junction in the groin.
Okay.
Then comes a really crucial step, injecting tumescent anesthesia all around the vein.
Tumescent, we hear about that. Why is it so important here?
It does a few key things. One, it numbs the area. It's a local anesthetic. Two, it gently squeezes the vein around the catheter, ensuring good contact for the heat.
Efficiency.
Right. And third, maybe most importantly, it creates this protective cushion of fluid between the vein and the surrounding tissues, like skin and nerves, absorbing excess heat.
Protecting everything else. What's in it?
Usually dilute lidocaine for numbing, some epinephrine to constrict vessels and reduce bruising, and saline solution.
Gotcha. So after the tumescent fluid is in,
the device heats those 7-centimeter segments one by one, pulling the catheter back each time. Heats the wall to about 120 Celsius. Once the whole faulty length is treated, the catheter comes out. Then they do another quick ultrasound check.
To confirm closure.
Yeah, confirm it's sealed, and importantly, check the nearby deep veins for any new clots.
And recovery. What's typical after RFA?
Usually compression stockings for, say, a week or so, though there's some debate now about whether continuous wear is always needed. Walking is really encouraged right away.
Get moving.
Definitely. And then a follow-up ultrasound, usually within a week, is important to look for something called EHI.
EHI? What's that?
Endothermal heat-induced thrombosis. It's basically a clot that can sometimes form at the top of the treated vein and stick out a little into the deep vein. It needs monitoring.
Okay. And other complications?
Well, early on, with some devices, there were slightly higher DVT concerns. But techniques have improved a lot. Otherwise, you can get things like vein perforation, superficial clots, nerve irritation, usually temporary tingling or numbness or skin bruising. But serious things like a pulmonary embolism are rare.
And long-term, RFA holds up well.
Yeah, the big European studies show really high long-term closure rates, like years down the line, and sustained improvement in symptoms for patients. Good results.
Okay, that's RFA. Now the other thermal one, EVLA Endovenous Laser Ablation. Similar idea, but using laser light.
Exactly the same principle, really. Minimally invasive, catheter-based. But instead of radiofrequency, it uses laser energy delivered through a fiber inside the vein to heat and damage the wall, causing it to scar shut.
And the sources mention different laser wavelengths, water-specific versus hemoglobin-specific. Does that matter much to the patient?
It's interesting. The research suggests that different wavelengths seem to work equally well in terms of actually closing the vein. But there's a trend suggesting that the higher wavelengths, the ones absorbed more by water in the vein wall, might result in a bit less pain and bruising right after the procedure.
So maybe a slightly more comfortable recovery with certain lasers?
Potentially, yeah. And another factor is the type of laser fiber tip, bare tip versus jacket tip or radial fibers.
How does the tip make a difference?
Well, some lab studies suggest that the older bare tip fibers might have a higher chance of actually poking through the vein wall during the treatment.
Ouch, more bruising.
Yeah, potentially more pain and bruising. The newer designs, like jacket tips or radial fibers, are meant to spread the energy out more evenly or avoid that sharp point contact, reducing the risk of perforation. And clinical results seem to back that up, less post-op discomfort.
So the tech keeps improving. What's the EVLA procedure itself like? Is it similar to RFA?
Very similar setup. Ultrasound guidance. Access the vein, place the sheath, insert the laser fiber up to just below the junction. Tumescent anesthesia is absolutely essential, again, for all the same reasons.
Numbing, squeezing, protecting.
You got it. One term you might hear with EVLA is lead.
Lead.
Linear endovenous energy density. It's basically how much laser energy is delivered per centimeter of vein. There's a balanced enough energy to close the vein effectively, but some studies suggest too high a lead might slightly increase the risk of temporary nerve issues, like paresthesias.
Paresthesias, like tingling.
Yeah, tingling or numbness. So doctors manage that energy delivery carefully, usually pulling the fiber back continuously while watching the energy readout. Post-procedure care is pretty much the same as RFA. Compression, walking.
And potential complications. Similar list.
Very similar list, yeah. Perforation, thrombosis superficial or rarely deep, including PE nerve injury, skin issues like burns or discoloration. There's also an extremely rare risk of an arteriovenous fistula forming. But again, higher wavelengths and jacket tip fibers seem to help minimize the common side effects like pain and bruising.
And the long-term effectiveness of EVLA, how does it stack up?
It stacks up very well. Initial trials were promising, and long-term follow-up confirms it's durable. Big reviews comparing it to surgery found EVLA is basically just as safe and effective, maybe even with less risk of neovascularization, new little veins forming compared to surgery. One big trial showed no real difference between EVLA and surgery even 5 years out.
Okay, so RFA and EVLA, two solid heat-based options. Let's switch to the NTNTs now. Non-thermal, non-tumescent. The big appeal is avoiding that tumescent fluid injection, right?
Exactly. No need for all those injections of fluid around the vein.
First up was chemical ablation, including foam sclerotherapy.
Right. Foam sclerotherapy isn't new, exactly. Doctors have been making foam from liquid sclerosants for a while, often using the Tessari method, and it works pretty well. But more recently, we have Varicose.
That's the prepackaged foam.
Yeah, it's polytoconal injectable foam, FDA approved specifically for treating the GSV, AASV, and those visible varicose veins lower down.
And studies show it works.
Yes, the big trials, Vanish 1 and 2, showed good vein closure rates, and patients reported feeling significantly better. It's worth noting, though, that a small percentage of patients in those trials did develop a DVT.
Okay, something to be aware of.
But overall, follow-up studies confirmed improvements in symptoms and quality of life scores.
Then there's MOCA, mechanico-chemical ablation. Claravane. Sounds like a combo approach.
It is. It uses a special catheter with a wire at the tip that rotates very fast.
Physically damages the vein lining.
Exactly. Mechanical disruption. And at the same time, it sprays a liquid sclerosant into the vein. So it's like a 1-2 punch.
Does it work well?
Studies show high technical success, good vein closure rates at a year, and improvements in patient symptoms. Good results reported for both the GSV and the SSV, and overall reviews suggest it's effective with low complication rates.
How does it compare to, say, laser?
There was one trial comparing MOCA directly to EVLA. Both improved symptoms and quality of life. But EVLA had a somewhat higher vein closure rate after 1 year in that particular study.
Interesting. Okay, the last NTNT, adhesive closure, Venclose, using glue.
Pretty much. It's a medical-grade cyanoacrylate adhesive similar to superglue, but formulated for medical use. Delivered via catheter, no tumescent needed.
How does it work?
The glue is injected in small amounts along the vein. As soon as it hits the blood, it polymerizes, hardens almost instantly, and essentially glues the vein walls shut from the inside.
Wow. And the results?
Initial studies were very positive. Longer-term trials show good vein closure rates, comparable to RFA actually, out to 3 years. Patients had similar pain levels right after, maybe even less bruising with the glue compared to RFA. Quality of life improvements were similar too.
Any downsides to the glue?
Well, there have been reports, though rare, of a delayed allergic type reaction, a hypersensitivity reaction to the cyanocrylate in some people.
Okay, so we've got thermal, chemical, mechanical, glue. When you look at all these Endovenous options together, how do they compare overall?
Well, some big analyses, looking at data over a couple of years, suggested that RFA and EVLA might have slightly better closure rates than foam sclerotherapy or traditional surgery.
But maybe not a huge difference in how patients feel.
Right. Another study that directly compared RFA, EVLA, foam, and surgery found that while foam had the highest technical failure rate, all four methods gave similar improvements in symptoms and quality of life at 1 year.
So the bottom line is,
The general consensus from major reviews, like the Cochrane Review, is that RFA, EVLA, and foam sclerotherapy are all safe and effective alternatives to surgery. They're at least as good, and among the Endovenous methods themselves, the long-term effectiveness and recurrence rates seem pretty comparable. Lots of good options.
that's really helpful. Okay, let's focus specifically on sclerotherapy now. We mentioned foam, but let's talk about the general idea. It's injecting a chemical.
Exactly. Injecting a chemical solution, a sclerosant, directly into the unwanted vein. The chemical irritates and damages the vein's inner lining.
Causing it to close up.
Yeah, it triggers inflammation, the vein walls stick together, thrombosis occurs, and eventually it just turns into scar tissue and fades. There are some situations where it might not be suitable, like certain allergies, pregnancy, active clotting issues.
And you tailor the approach based on the vein size, liquid versus foam.
Absolutely.
Yeah.
For the really tiny spider veins, liquid sclerotherapy is usually the way to go. For slightly bigger reticular veins or small varicose veins, foam often works better because it displaces the blood and has more contact with the vein wall, or sometimes stronger liquid concentrations are used. You might even use both in one session.
What kinds of chemicals are used? The sources mention different categories.
Right, there are osmotic agents like hypertonic saline, they basically dehydrate the vein cells. Alcohol agents like glycerin damage the cell membranes. And then detergent agents.
Detergents, like soap.
Sort of, in terms of mechanism. They disrupt the cell surface. Common ones are STS, sodium tetradecyl sulfate, and polidocanol, which is available as a sclera for liquid use, and Varithena as the foam. Each type has pros and cons.
Okay. And before starting sclerotherapy, what planning is needed?
Good before. Photos are key for tracking progress.
Yeah.
It's also helpful to mark the larger veins while the patient is standing up, when they're most visible.
Right.
And managing expectations is crucial, explaining that it often takes multiple sessions. Then you decide on liquid or foam, and the right concentration of the agent for the target vessel size.
What's the actual injection process like?
For liquid, the sclerosant is diluted appropriately and then injected using very fine needles, usually starting with the larger feeder veins and working outwards. Slow injections, applying compression right after.
And for foam?
For foam, you create it usually by mixing the liquid sclerosant with air or gas, often using the Tesseray 2-syringe method. Then, especially for larger veins, ultrasound is used to guide the needle and watch the foam fill the vein. Compression follows that too. Sometimes a catheter might be used for bigger veins.
What about aftercare? Compression again?
Yes, compression stockings are standard afterwards.
Yeah.
The duration might vary depending on how big the treated veins were. General advice is resume normal activity, but avoid really strenuous leg exercise for maybe a week or two.
Anything else to avoid?
Usually advised to avoid aspirin or ibuprofen and things like hot baths or saunas for about 48 hours.
Okay. And complications. Are they common with sclerotherapy?
Most are minor and temporary. Things like hyperpigmentation, some temporary skin darkening along the vein, telangiectatic matting, new tiny spider veins appearing near the treated area, which usually fades. Some bruising or soreness is common, maybe temporary hives.
What about serious issues?
They're rare, thankfully, but can include skin necrosis, like a small ulcer, if the solution leaks out. Superficial thrombophlebitis, inflammation of a treated vein. Nerve damage is possible, but usually temporary. Allergic reactions can happen. DET and PE are very rare risks. And accidental injection into an artery is a serious, but again, very rare complication.
But overall, for the right types of veins, it's effective.
Oh yes. Lots of studies show good results with both liquid and foam for spider veins, reticular veins, and even some smaller varicose veins.
Oh, sure.
Ultrasound-guided foam in particular has expanded its use.
The sources also pointed out some key references, sort of landmark papers in this field.
Yeah, they highlighted a few that were really influential. Papers on the early work with foam sclerotherapy, understanding how laser actually affects the vein wall, the development of that segmental RFA technique, using polidocanol microfoam, the big comparison studies, and the work on mechanochemical ablation. Foundational stuff.
Got it. Well, this has been incredibly comprehensive. It really feels like we've covered the waterfront on modern varicose vein treatments based on these textbook chapters.
It's clear things have really evolved, hasn't it?
It definitely. Beyond the old stripping surgeries.
Absolutely. And the main takeaway for you, the listener, is that there's now this whole toolkit of minimally invasive options: RFA, EVLA, foam, MOCI, Veneseal, sclerotherapy.
Lots of choices.
Lots of choices tailored to different vein problems and patient needs. And it's reassuring that this info comes from such an authoritative source like Rutherford's. These methods are well established.
And this is crucial, we've covered a lot of technical ground. It really underscores the need for a proper medical evaluation, doesn't it?
Oh, absolutely.
Yeah.
This isn't a substitute for seeing a doctor. You really need to consult with a vascular specialist.
Right.
They can do a proper assessment, including that duplex ultrasound, figure out exactly what's going on in your specific case, and then discuss which of these options makes the most sense for you.
Couldn't agree more. That personal consultation is key. So thinking ahead, with technology moving so fast, it makes you wonder what's next. What other innovations might be coming down the pike to make treating venous disease even better, maybe even more personalized?
That's the exciting question, isn't it? Always something new on the horizon.
Definitely food for thought. Thanks so much for joining us for this deep dive.